Toiten La Camera. I'm going to talk about the chemical remission. What are the challenges and how new biological agents can do. And this is my disclosures. And today's topics include, first, importance of the earlier diagnosis, and second, activity measurement aiming the treatment goal, and third, endocytes as a key pathophysiology of SPA. And lastly, efficacy and safety of R17 targeted therapy. So I'm going to move on to the first topic. As you all know, spondyloarthritis, SPA, is characterized by active axial joint inflammation and also by the association with HLA-B27 positivity. That's the reason why currently Suffolk syndrome is not included in spondyloarthritis, because Suffolk syndrome is not associated with HLA-B27 positivity. And this is a typical spinal radiograph showing that bony bridging and bamboo spine formation in thoracic and lumbar spine. And this one shows the association with HLA-B27 and ankylosing spondylitis. So prevalence of ankylosing spondylitis varies among population or countries, but roughly 0.5% of population. However, it's 10 times higher, around 5% in HLA-B27 positive populations. And it should be noted that less than 10% of HLA-B27 positive population develops ankylosing spondylitis. And in other words, around 90% of patients with ankylosing spondylitis shows positivity for HLA-B27 test. And this is the ASUS classification criteria for axial SPA. Entry criteria is more than 3 months back pain and age at onset less than 45 years, younger onset back pain. And afterwards, there's 2 arms. One is imaging arm, sacroiliitis on either MRI or radiographs. But MRI and radiographs differs a lot because MRI can detect active inflammation despite the presence or absence of structural damage. However, radiographs only detect structural damage irrespective of the presence or absence of active current inflammation. And another pathway is clinical arms, defined by HLA-B27 positive. And in addition, we need some SPA features, 1 for imaging arm, at least 2 for clinical arms. And SPA features include inflammatory back pain. Inflammatory back pain is not equal to the entry criteria back pain at the age of less than 45 years. For example, this is the ASUS inflammatory back pain criteria. Age at onset less than 40, not 45, and insidious onset. And it is very typical that improvement with exercise and no improvement or worsening with rest. This is a big difference from the mechanical lumbar lesions. And that's why pain at night with improvement upon getting up. And this is the current concept of spondyloarthritis subgrouped into predominantly axial SPA and predominantly peripheral SPA. Predominantly peripheral SPA includes reactive arthritis and psoriatic arthritis, IBD-associated SPA, and others. But it's a group level. For individual level, it's sometimes different. For example, some patients with psoriatic arthritis can be predominantly axial SPA, and we call those patients axial PSA. But at a group level, this classification is true. And such kind of individual level and group level is very important because we diagnose at an individual level. So diagnostic criteria is for individual person and classification for just group. And axial SPA divided into radiograph and non-radiographic. And this is a sacroiliitis by MRI and X-ray. As mentioned before, MRI can detect active inflammation irrespective of the presence of structural damage. And radiographs only detect advanced phase of sacroiliitis. So, all the axial SPA start from non-radiographic stage, and some patients advance to radiographic stage. And for ankylosing spondylitis, usually structure change starts from sacroiliac joint and go upwards to spinal bone. That's why modified New York criteria only included radiographic change in sacroiliac joint, because mostly this is the first site for observed the radiographic change in AS patient. But for some axial PSA patient, cervical spine damage can precede to sacroiliac joint damage. And this is a modified New York criteria for ankylosing spondylitis. And radiological criteria says that sacroiliitis at least grade 2 bilaterally, or at least grade 3 unilaterally. Grade 2 is defined as the presence of erosion or osteosclerosis without the alteration in the joint space width. So no narrowing, no widening. And grade 3 is defined as more spreading erosion or osteosclerosis leading to the alteration in joint space width, widening or narrowing. That's a grade 3. And also grade 4 is total bony ankylosis. And clinical criteria includes inflammatory back pain or inflammatory-like back pain, and limitation motion of the lumbar spine, and limitation of chest expansion. So this slide shows the ratio of non-radiographic axial SPA to ankylosing spondylitis among patients with axial SPA in relation to symptom duration at the time of diagnosis. For very early patients, duration less than 1 year, around 30% shows radiographic change called AS. In contrast, patients with disease duration more than 10 years, then it is totally opposite. Only 30% shows non-radiography at that time. So during that observation period or disease duration, many non-radiographic patients advance to radiographic. In other words, ankylosing spondylitis. That's why average delay in diagnosis is calculated as 9 years. It's a very big. And during that period, active bone inflammation called osteitis in MRI changed to erosive change with some repair. But with some repair is okay, but sometimes over-repairing phase causing new bone formation, called C-desmophyte and leading to bone breaching and total ankylosis finally. And this slide shows the clinical cost of radiographic damage over time at a patient level. So you can see many patients show the radiographic progression over time. In addition to radiographic progression leading to disability or decreased quality of life, disease activity is also associated with increased mortality, such as elevated CRP is associated with mortality. That's the reason why early recognition and diagnosis and adequate management is mandatory. And ACES endorsed recommendation for early referral. This early referral statement is very close to classification criteria for axial SPA, including the inflammatory-like back pain, and also HLB27 positivity described in the clinical arm, and sacroiliitis on imaging on the imaging arm, and some SPA features including inflammatory back pain or peripheral arthritis and so on. Then I'm going to move on to the second topic, activity measurement aiming the treatment goal. This one shows that conventional DMARDs are largely not effective for the treatment of patients with ankylosing spondylitis, including sulfasalazine, leflunomide, and methotrexate. But the interpretation of this data belongs to. One is actually not effective. And other interpretation may be BASDI is not adequate measure for disease activity or efficacy of these drugs. But correct answer is former. So this slide title is correct. Because currently, ASDAS, ankylosing spondylitis disease activity score, has been validated for very good activity measure. And ASDAS parameter includes total back pain. It is BASDI question 2. Duration of morning stiffness. It's BASDI question 6. Peripheral pain or swelling. BASDI question 3. In addition to patient global assessment of disease activity and C-reactive protein level. And this is the ASDAS calculation formula. Some of you are math genius and easily calculate, including the logarithmic transform. Why logarithmic transform is required for CLP? Because its distribution. CLP distribution is highly skewed, so kind of here-like. And others are more symmetrical distribution. That's why for CLP, logarithmic transformation causing the symmetrical distribution is required for addition to other parameters. And this is the ASDAS cutoff for status sources. And we should aim the inactive disease called ASDAS score less than 1.3. And this is the reason why ASDAS should be used. Because the association of ASDAS score with radiographic progression has been demonstrated very, very clearly. So if you see figure C, newly formed C-desmophyte is clearly associated with very high disease activity and almost none in inactive disease. And it is also true for peripheral SPA, including psoriatic arthritis. And psoriatic arthritis, we use minimal disease activity, already mentioned, or DAPS. Because the same reason, DAPS and MDA has been validated due to the relationship between disease activity state and radiographic progression. So that leads to the algorithm based on update of treat-to target recommendation for SPA. We should aim at the remission state. That is the main target. And for some patients, alternative target can be low disease activity. And we should adapt therapy if that state is not achieved, or once achieved and followed by its losing. So third topic is ensitis as a key pathophysiological feature of SPA. The word ensitis has two meanings. One is clinical ensitis, and another one is subclinical ensitis. Clinical ensitis can be detected by the presence of tenderness on some specific points. For example, messages recommending 13 sites described here, including Achilles tendon insertion site. But if we push some specific point and patient says, ouch, but it is not necessarily meaning that the ensitis is there or inflammation is there. So to avoid confusion with fibromyalgia or as a non-inflammatory state, we should confirm the presence of ensitis by ultrasound or in some sites MRI. But ultrasound is less expensive, so ultrasound should be the first choice for confirmation of the presence of ensitis. And next, I'm going to talk about the subclinical ensitis, because you know dactylitis is a whole digit swelling, but dactylitis also starts from ensitis. And US examination clearly shows that dactylitis is multifocal ensitis and the inflammation spreading from endothelial site to whole digit, including some cutaneous lesions or whole tendon. It is also true for nail disease and DIP arthritis. So ensitis occurs around the DIP joint, then it subsequently develops secondary synovitis of DIP joint, and also nail change such as nail pitting or onycholysis. So first start from ensitis, and it subsequently causes nail change or joint synovitis. And what's the molecular mechanism of ensitis? It has been demonstrated that various important cytokines, such as R22, IL-23, and TNF, as well as R17, is very important for the development of ensitis. And TNF inhibiting agents such as infliximab or adalimumab shows good results. For example, ASAS40 response around 40%. But placebo response is more than 10%, so difference between placebo response and active drug response is around 30%. So still many unmet needs. So R78 is a key cytokine that drives enzymes. And the production of R17A has two pathways. R23 dependent, in other words, acquired immunity-associated pathway, and R23 independent, innate immunity-dominant pathways. And both pathways lead to R17A overproduction and enzymes, followed by inflammation, pain, loss of function, and bone damage. So, R17 blocking should be very useful for actual SPA. So, final topic should be efficacy and safety of R17 targeted therapy. This measure 1 study is for active ankylosing spondylitis and demonstrating low radiographic progression and sustained efficacy through 4 years. So this is a radiographic result showing that regular dosing of secukinumab 150 mg is very effective for inhibition of radiographic progression as compared with half dosing 75. And around 80% of patients showing radiographic halting with secukinumab treatment. And clinical response is very favorable throughout 4 years. For example, ASAS20 around 80%. And it is more important because that ASAS20 response very high is irrespective of TNF-IR patients or TNF-naive patients. And can be very surprising that even in anti-TNF-IR inadequate responders, 80% of patients showing favorable response to secukinumab, as well as anti-TNF-naive patients. And about the safety profile, R17 blockade has some merit as compared with TNF blocking because less infectious complications overall. And serious infection only 1% more appropriately 1 per 100 patient years. Also, the development of inflammatory bowel disease is very rare. And also, almost no malignancy. And candida infection is very rare because we know that R17 or T17 cell is very important for protection against fungal infection. So our worry about the candida or other fungal infection was still there, but data showing that candida infection is not so frequent and mostly not severe. That's a very important point. And about for psoriatic arthritis patient, Future 5 studies showing that very good primary outcome clinical response in terms of ACR20 response as compared with placebo. Secukinumab 300 mg showing very good response. And when we compare anti-TNF naive and anti-TNF inadequate response patient, almost similar. You may say that less response in anti-TNF-IR patient, but when we compare the placebo response rate, it is not so. Because the difference between placebo response rate and 300 mg response rate is similar between anti-TNF naive patient and anti-TNF IR patients. And also, 300 mg secukinumab treatment shows very good radiographic progression inhibition, and also some for 150 mg secukinumab treatment against placebo. And in addition, secukinumab treatment shows very favorable resolution of encephalitis, the clinical encephalitis, and dactylitis. In summary, early diagnosis is crucial for better outcome of SPA. Treat to target strategy is a mainstay of the management of SPA. Encephalitis driven by R17 is a key feature of SPA. And finally, the inhibition of R17 is a reasonable clinical option for SPA treatment with a favorable risk-benefit balance. Thank you for your attention.